Attachment and early attachment tears have a significant impact on addictive disorders. And it's something that doesn't really get the kind of weight it should in treatment programs. So, right, the therapeutic relationship is the key. It's almost the first healthy attachment, or it should be, for an addictive person. And that doesn't happen.
Liz, welcome to the show. For anybody that doesn't know you and isn't aware of your work, can you maybe tell us a bit about your background and what initially sparked your interest in working with addiction?
So I've been working with various behavioral and chemical addictions probably for in and out for my whole career. Even when I was going to graduate school, my first internships were in drug treatment programs. I've have some friends and family who've had addictions, so I had an interest in what would make a person take apart their lives the way addictions can do, and that's really kind of what got me into addictions. Yeah.
Wow. Okay. Now, before this interview, you sent me some information
Yeah.
with statistics from a review article showing that
Yes.
out of 122 studies looking at treatment outcomes, 96% were focused on patient factors only. Why is this such a problem?
Because essentially it's pathologizing patients or clients. So if you're only looking at patient factors, essentially you're putting the onus of the treatment success only on your patients, without ever looking at what effect is the treatment itself having on the patient. What other field do we do that in, right? If someone is depressed or someone has cancer and they're being given a cancer treatment and it isn't working, the patient doesn't get blamed for that. The treatment is changed, right? But not an addiction treatment.
That just makes so much sense. It's almost common sense, but I can't believe that's the case. 96%.
96%. 200,000 patients in that systematic review paper. Unbelievable. Wow. 96% all looked at patient factors only. It's pretty remarkable. Yeah.
Whenever we're talking about, different treatment approaches to healing addiction and working with addiction, what do you see as the most common flaws in addiction treatment as it is commonly practiced? And why do you think relapse rates are so high?
Although we know that we'll say that they're complex disorders, I don't think we really treat them as if they're complex disorders, right? And we also don't treat them as if they're chronic. They're going to be chronic disorders. So we're trying to help people be cured, right? Abstinent within 90-day programs, 6 months programs, and we kind of superimpose these behavioral changes without looking at all of these factors that are contributing to addictive disorders, right? We know so many things contribute to it. And right, from my perspective and from a schema therapy perspective, attachment and early attachment tears have a significant impact on addictive disorders. And it's something that doesn't really get the kind of weight it should in treatment programs. So, right, the therapeutic relationship is the key. It's almost the first healthy attachment, or it should be, for an addictive person. And that doesn't happen. Still, even after all these years in addiction treatment, they're still using terms like therapeutic discharge, right? What therapeutic discharge, willingness, the person has to hit bottom. Right? There's still like all these punitive terms, as if the person needs to be punished more somehow before they're going to be willing, rather than, again, maybe their attachment, maybe their inner critic is actually making this addiction much worse. Maybe they're going through some kind of a cycle, and there are all these different, and from my perspective, there are these different, what used to be called self states, right? Which in schema therapy we called mode states, where you see somebody coming in for treatment, and one day they are very willing. They've just gone through something terrible, and they're really feeling the effects of their addictive disorder. And you have them in a place where they're like ready to make changes. You work with them, and then the next time you see the person, all of a sudden they've shifted mode states, right? They're kind of back into protecting a behavior that has actually helped them in some ways through life, right? So they have shifted mode states, and now they're minimizing it. And traditionally, treatment sees this as somebody in denial. Those are words, right? Those are words that would be used. Now they're in denial, rather than something happened over the last few days where it started to feel like the addiction was going to be the only thing to meet their needs somehow. So they started to protect the addictive cycle again with this minimization somehow. So we need to look at, connect with the person, number one, really connect. And just talk to them about, like, hey, this just seems to be a shift from what we talked about last time. I'm wondering what happened internally, right? Remember, in a lot of ways, your addiction makes sense. Right? It really does, and they do. If you look at a person's addictive disorder, you can trace it back to childhood most of the times. Right? And you can see why it started to get steam, why it continued over time. It makes a type of sense. And when you approach it that way with the patient, they feel like you understand them. You do understand them, right? Because it does make sense. But there's faulty reasoning as time goes on. So, and then approaching by looking at, okay, so it does do this for you, but it also does this, right? And it's starting to not align with who you really are, who you want to be in the world. And also getting those real needs met in a way that feels good, that doesn't have all these horrible side effects, right? And can make you feel good on the inside, right? Without that. So those are, I think that so much of that is missing in current treatment. It's go to meetings, you go to AA, or go to, sex addiction treatment programs, stop the behavior, work your steps harder. And that does work for a small percentage of the population, but we're missing so many people. Because if you already have trouble with attachment, and you have to go into meetings where you've got to attach to others, how are you going to stay? Right? How are you going to work out a conflict? You don't. People end up leaving, and that's where you end up with these high rates of relapse, and a defeatist feeling like, I can't make it, I'm a failure, right? When it's the treatment itself that's lacking. The treatment is not complex enough, or holistic enough is the way I would put it, holistic enough to help the person really heal and understand what's happening. Right? Because there's this other thing that happens as people go through treatment. I was just talking to a patient of mine about this last night. So things start to get better. You start to feel better. The addiction starts to, right? The behavior of the addiction starts to calm, right? You stop the behavior or the chemical. And then all of a sudden, all of the things that were behind it start rising right to the surface, right? In schema therapy, we would call that schema activation. So all the perfectionism, all the pressure, all of the unrelenting standards that we have for ourselves, our inner critic, get louder. And for this window, it starts to feel, our trauma, all the old trauma comes up. It starts to feel like, oh shit, I made a mistake. I need to go back to that. I can't handle all this pain. All this pain comes up. And we as clinicians, we have to help people anticipate this. Know that this is normal. Help them heal that. Expect it, right? Know that these mode states are going to tell them to run back to the addictive cycles, and give them real ways to heal what's underneath. Without doing that, why wouldn't you run back to the addiction, right? If all of that comes back, I have somebody I work with who he had gone through many rehabs, and then we started to work together. And what would surface is the behaviors would stop. His addiction was to BDSM, which is a sort of a bondage, and when that would calm down, he would start feeling tremendous pressure to be good, to be perfect, to get everything right, right? And that addiction let him off the hook for that schema activation. So we had to very quickly go in and re-script and help him stand up to that voice that would tell him that inner voice, these inner states that tell you to get everything right and do everything right and dot every I and cross every T. It's too much pressure. No one wants to live in that. So as we were able to kind of untangle that and calm that down, he was able to stay abstinent longer and longer, and he's doing much better now.
Why schema therapy over other forms of therapy when it comes to addiction work? What's the unique contribution that schema therapy can make to both our understanding and treatment of addiction?
I am so glad you asked that question. That's a great question. So first off, schema therapy has a track record of evidence treating complex disorders, right? So there's a lot of evidence if you look in the literature, especially like Arno Arnst and Eshkol Raffaelli, Matt, and lots of other people, Scott Kellogg. You'll see there's so much evidence behind it. Also, the literature bears out that right now, somewhere around 60% of people with addictive disorders also have personality disorders or personality problems often. And again, schema therapy, that's what it was developed for. Complex trauma, borderline personality disorder, narcissistic personality disorder. So it both treats these complex disorders and the personality issues, right? It's a developmental model. So it's meant to treat these early attachment issues and core needs, right? It's it's all of the things that go into creating these addictive cycles. So it's complex enough to handle all of the different mode states of people with addictions. That's why. Also, we have a very, very good track record of retention, right? The concept of the therapeutic relationship and the emphasis on it really helps to connect patients to their therapists. And as a friend of mine always says, the most important part of the treatment is the treatment, right? You can't help people if they don't stay in treatment. So because of that, because we really know how to repair attachment tears, there's a lot of attention, very similar in some ways to DBT, which is that if there's any tear between the therapist and the patient, that has to be attended to first, above all else. Because if you don't, right, because people are not comfortable or they don't feel warmth that you genuinely care, they're going to cut out of treatment. And that's it, right? The end of treatment. So those are the reasons I think schema therapy is really well positioned to treat addictive disorders. And by the way, I'm not someone that thinks schema therapy, I love schema therapy, but I don't think it's good to treat everything. But it definitely is set up to treat addictive disorders.
Fantastic. Now, what would you say the aim of schema therapy is? What's the core aim?
The core aim is to strengthen the patient's healthiest adult mode, right? The healthiest adult mode, and to really help the patient meet their core developmental needs, right? And those things go hand in hand.
You know, this is a common theme in a lot of sort of people I've interviewed on this subject. This idea of developing sort of like an internal secure attachment between a mature self or adult and these younger, more vulnerable, more immature parts of ourselves. And you're sort of like parenting from the inside, you know?
Exactly.
And I was just curious to ask, well, I don't know why this came to mind, but how has having such an in-depth understanding of schema therapy and this approach improved your own quality of life, if at all?
Oh, it did my own quality of life. It's changed my life completely. I can't tell you how much, like, emotionally, personally, I've gotten much, much better at just understanding my own mode states. I found recently I had one of these moments where I realized I was in what I call survival mode. I felt like a little bit panicked about something that was going on at home. And I was like, oh, I just shifted into survival mode. Wait a minute. Survival mode is a child mode that I had, right? Going back from when I was 14, 15 years old. So give me a second, and I could feel myself shift back into my healthy adult mode and much more able to then address what was going on. I didn't need survival mode anymore. And what schema therapy and some of these parts-based, self-state-based therapies are really about is knowing you have choice. It's not that these modes won't come up now and then, right? Just like the urge to maybe drink or go back to the addiction isn't going to occur to you, but you start to really have choice. You can choose your healthiest adult mode over time, which is amazing. So I've been able to more and more choose that mode, right? Today for the interview, I could get into that panicked, insecure child who is in middle school, right, having to give a speech. But instead, like, I can take that part of me and have little Liz sit over on the side, and she can watch, and adult Liz can be part of the interview.
Now, whenever you are, let's say you notice that you're in that maybe 14, 15-year-old mode, this
Yeah.
more kind of, um, what does the process actually look like for you internally? Or is there internal dialogue there, or how are you relating with that part of yourself to shift back into an adult mode?
So if it were me personally or for a patient, so the process of doing that, like the process of doing that is based on, like, if you're working with a patient, I'll tell you me in a second. If you're working with a patient, it depends on your case conceptualization. If you have a patient, you're working with someone, let's say, who has an addictive disorder, and you know because of their history that, right, there's a lot of abuse, there's a lot of trauma, right? There's probably, let's say, not a very strong, healthy adult mode right now. It's there, but it's not very active. For a while, the therapist has to step in to take the place and almost model that healthy adult to the person you're working with. So we do chair work doing this, we do imagery, everything about strengthening this healthy adult mode. But we're very, very careful when we do this. So if I do an imagery exercise with someone where I go into and meet that 14 or 15-year-old self that feels insecure, that feels afraid, after the imagery exercise, I'll always tell the person, remember, I only represent the healthy adult you. I'm giving you the messages that you should have gotten back then.
Mm.
So we'll go in, set healthy limits, help with attachment, help with real validation, give the messages that should have been given. And so the more we do that, the more the child self knows actually what it would have felt like to have those needs met. It's different than intellectual knowledge. When you use imagery and chair work and emotion focused techniques, you really know what it feels like to have the need met, to feel attached, to feel loved. So does that make sense?
That's so interesting. So the therapist in that context first acts as a model, as a
Yeah.
template, and
Yes.
then does the chair work, does the imagery work, and then over time, the client internalizes that
Correct.
model, and that becomes a stronger part of them, because in a lot
Right.
of these cases, they might never have had a figure like that in their lives to learn this from.
That's right. And so right. And so within imagery, you would do it that way. If you're doing chair work, Scott Kellogg, I usually use, I like Matt's work. I like Scott Kellogg's work around the 4 dialogues in chair work. And for a little while, we usually have to play the adult, right? If you're doing it on chairs, because it's hard at first for somebody with an addictive disorder, trauma, or anything to hear the healthy adult voice. Sometimes what they consider the adult voice is actually an inner critic, right? Especially if we grew up with critical parents. So we help shift that a little, chair to chair, so they can really start to differentiate these different states. That's what starts to help them realize and really feel when they're in a state other than a healthy adult mode, right? And so it gets stronger and stronger over time, and over time, choice becomes available.
Now, I want people to know,
Yeah.
whenever you say Matt, we're talking here about
Oh,
Matthew Pugh. He's a clinical psychologist in the
yes,
UK from
yes,
Chairwork UK, and Scott Kellogg. He's actually given a talk with us before. He's brilliant on his 4
yeah,
dialogues. So
yeah,
big fan of Scott too.
yeah, me
Um,
too.
we're throwing out a lot of terms here, so I want to define a few now, Liz, if you don't mind. For
Sure.
anybody that wants to know, like, what is a schema? How would you describe a schema in simple terms for somebody?
A schema is an emotional and cognitive map, how you see yourself, others, and the world that develops as you grow up. For example, something very simple, I'll give you a maladaptive schema to make it simpler. So if let's say you grow up with parents who lie to you, right? And lie to each other, you will likely develop a mistrust schema. Schemas are adaptive in a way. We're trying to learn how to interact with others and the world around us when we're younger. So we would develop a mistrust schema. Where it becomes maladaptive is we take that trait and we bring it into adult life where it doesn't fit anymore, right? So you're growing up with parents who lie to you. Yeah, you can't. The truth is you can't trust. You are being lied to all the time. But now you're 25 and you're in the world with other people, but you're still approaching through the veil of this schema that I can't trust others. And behaviors result from that thought and feeling that get generated. That's what a schema is.
So essentially, our perceptions of the world are all limited, are limited, and we've all got these maps that help us to make sense of our experience and everything. And if somebody has a maladaptive schema, they've got something that maybe served them at a young age to help them get through a difficult situation, but now that is leading to maybe difficulties in their personal life and their relationships. And maybe the job of a schema therapist is to help them maybe correct that map so it more aligns with the territory as opposed to the territory from the very young child.
That's right. And so these maps, right? These various maps occur, and pain results from them. If they are maladaptive schema, pain results. And from that pain, we end up with certain coping modes, and these are the mode states to cope with that pain. And depending on temperament, what's modeled around them, they can choose any number of coping modes, whether that's overcompensation, whether that's surrender, whether it's detachment, right, to cope with that pain. And so different behaviors will result from these different coping modes.
The more we sort of get to this conversation, the more it makes sense why schema therapy is such an effective treatment for addiction, because anyway, we'll get to that. But I want to ask, I heard in another talk recently about this, that schemas can potentially be transgenerational. What are your thoughts on that?
There's no studies around it, but it certainly makes sense to me that they would be transgenerational, in that our ideas and perceptions are certainly passed down. I think about my own history. My father grew up in the Depression, right? He was very young, but he grew up in the Depression, and his parents did. I ended up with a deprivation schema when I was younger, which I'd say I'd mostly healed now. So that deprivation and that sense of deprivation started a long time ago, and certainly got communicated from my father to me. So in that way, yeah, I would say.
I'm putting you in the spot there, no, that's very well said. And you mentioned there before about modes. What is a mode, and how does a mode relate to a schema?
So a mode is it's an emotional and behavioral state. They're temporary states. So if you think about the schema is a trait, and the mode is a temporary state. that we go in and out of to cope with schema activation. Right? And there may be, within a mode state, there may be several schemas that are activated within them. That's a mode state, right? Self state, right? Parts, right? IFS talks about these different parts of self. They're like that. And depending on how well integrated someone is, some mode states are more, you're more aware of than others.
What would you say are the main, I'm not sure how aware of IFS work you are, but if you are, what would you say are the main differentiating factors between IFS and schema therapy? Because to me, there's so many parallels. It's crazy. Like
there are a lot of parallels. I'm not as familiar with IFS because I'm a devotee of schema therapy, and it really came before IFS. I know that states of detachment aren't talked about as much in IFS, and that's critical in addiction treatment. Because really the central addictive state is a it tends to be a self-soothing or thrill-seeking detachment mode, right? It stops all feeling. Detachment, it's a mode that can get missed in therapy because somebody can come in. Actually, I have a better example. TV representations of therapists are usually of a detached mode, right? Right? They're sort of sitting there behind their paper talking. There's really no emotion there. They're these blank slates. That's right. That's a detached mode, right? It's not connected. You don't feel their presence. So addictions centrally are a detachment from all of this pain. They just shut it all down.
brilliant. Now, I actually asked Dick Schwartz about this, not about schema therapy, but IFS and his thoughts like on links with attachment theory. And he was saying that the difference that IFS has in its understanding of these things is that the way you were saying earlier that the therapist models the secure attachment figure,
Yes.
models the healthy adult,
Oh, yeah.
and then the client gradually internalizes that.
Right.
In the IFS model, they assume that this is there inherently in each human being, and it's only a matter of bringing it out of them. So that I think that might be the main distinguishing factor here. Schema therapy assumes that has to be learned. Yeah. They assume that it's innate.
We don't assume that it has to be learned. We base how strong someone's healthy adult mode is on our case conceptualization. So when we do the thorough assessment, we're looking for, in this particular person, how strong is this mode? How aware are they of it? How connected are they to it? That's going to vary widely, person to person. Right? I have some people who come to my office who they have very strong healthy adult modes, even with addictive disorders. Right? It depends on what the comorbidities are, how much trauma they had, how many healthy adults did they have in their life, and others very, very little healthy adult mode. They can't even recognize what that might be like.
Now, earlier we spoke about how addictions are often a result of core developmental needs not being met at a young age.
Mm-hmm.
What are some of, whenever in your addiction work, what have you found some of the most relevant developmental needs that aren't being met? What are most relevant in this situation?
So maybe I'm going to answer that by first describing the sort of the core schemas that all addictive, I mean, in my experience, all addictions have, and then the needs that are underlying those. So I don't think I've ever worked with anyone with an addiction that didn't have an emotional deprivation schema, right? An insufficient self-control schema, and a social isolation schema. Those three are always there, and almost always a defectiveness shame schema. Now, one might say that defectiveness shame might result from an addiction. And that's true. It reinforces that schema. But if you really look at the history, it predated picking up the addictive behavior. So you can see all of these things before the addiction takes hold. So the needs under emotional deprivation, right? Emotional deprivation is one of those schemas. It's hard to pin down because it's the lack of. This is the schema that will escape. Someone will come in for treatment and will tell me, I don't know why I have such a bad alcohol and sex addiction. My childhood was fine. I had everything I needed. It was all right. I didn't have all this trauma, all this crap other people have. And then as it gets unpacked, I'm thinking of one person I worked with in particular. He started to talk to me about how, well, now that I'm looking at it, if I came home from school and I had a fight with my friend and I really felt bad about it and I went to my father, he would just say, you don't need that friend anyway, right? And he said, and by the time I hit 11 or 12, I would feel crappy. I didn't have anyone to go to. And I'd go in my room and get on my computer and I would start looking at pornography and things like that. Like that's where I guess I realized started to escape there. So the need there, right, was for this attachment, this emotional connection. Like, yeah, that's normal, right? This validation, your feelings make sense to me, right? They're okay. I give you soothing and comfort and feel like things are going to be okay. Maybe good direction, good, healthy direction. With insufficient self-control, that schema, usually that happens because people either have overly strict parents or parents who didn't set healthy limits, right? So an addiction can feel like freedom, right? If you have a parent where they're like on you for every little thing, and you walk into a bar and let's say you're in a drag club and it's fun and colorful and full of dancing and all sorts. It's like, yay, it's freedom, right? So it can go that way, right? And it can go the other way, which is also the parent didn't set healthy limits, didn't teach the child how to stick with things that were difficult and to how to tolerate negative affect in a way that wasn't punitive. So healthy limits is important. Sometimes what people will ask me, which you haven't asked me yet, is if the focus is on attachment and it's on developing healthy adult and healing these old schemas, what about all these behaviors that are bad behaviors, right? Or destructive behaviors, self-destructive behaviors, destructive to others? The answer is healthy limits, right? Healthy limits is a real need. Punitiveness, right, is not an approach. It is not an approach a parent would take. So it's not an approach we would take, right? Our approach is empathic confrontation, right? Which has a very, very different feel to traditional addiction treatment. Social isolation schema is really about feeling a part of. Most addicted people will say that they feel it. AA uses the term terminal uniqueness, right? This feeling like no matter who they're with, no matter what group they're with, they don't fit in. They just don't feel part of, right? So the feeling of feeling a part of is a core developmental need, to feel a part of your family, like who you are at core as a human being fits, right, and is accepted in your family. So you see these things going from back then and then show up later.
This is a masterclass here, Liz. This is getting so much
Oh,
here.
good.
So just to sort of recap on the
Yes.
four things you said there: emotional deprivation,
Yeah.
self-control, social isolation. What was the fourth one?
Defectiveness, shame.
Defectiveness, shame. Okay. And whenever these needs aren't met, then often an addiction might emerge almost as a symptom of these needs not being met. And maybe the work then of a schema therapist in this context is to find healthy ways to get these core developmental needs met. Right. And then maybe the addiction becomes less attractive because they go, oh, I'm actually getting this in a way that is good for my whole system.
Absolutely. And one of the modes that is key to treatment and blocks the therapist's ability to even get to the addictive modes is a surrender mode. And really what that means is it's surrender to the messages of these schemas. So, for example, if you feel like you'll never have your emotional needs met, but that's just not possible for you, right? That's surrender. That's saying this is just how it is for me. If you believe that, why wouldn't you continue with the addiction? Right? If you are never going to feel okay, it wouldn't make sense to give the addictive disorder, because at least with the addiction, you have periods of time where you don't have to feel bad. So the therapy is about helping people see you're surrendering to these schemas, and you as a therapist starting to give this person experiences that are different, where they can see at least a glimmer at the beginning, like, wait a minute, I've been buying the message I got as a child for my whole life. And maybe there is a different way. Maybe I could feel okay, and not just okay, better without the addictive disorder.
That must be such a liberating realization for somebody to have. Like, I can't imagine anything more freeing than that, you know? Yeah. And I can see why these, I don't know if it's the exact word that's used, but I can see why some schemas are called life traps in that sense, because you're trapped.
They are. If you're surrendering to these, you don't even know you're surrendering to it, right? It's like we all see through these schemas, these filters that we were taught how to understand the world. It can trap you. It absolutely can. But yeah, Jeff Young's his self-help book, he didn't call them schemas in the book. He called them life traps. That was reinventing your life. Yeah.
Now, let's imagine that someone was to come to you with an alcohol addiction, okay?
Yep.
And I want to give people an idea of what the process, like the case conceptualization might actually look like. So what would your sort of first steps be in that situation? How would the therapeutic process look?
The very beginning of therapy, right, is going to be a balance between these emotional needs and this mode work, right, and helping with these self-destructive behaviors, right? They fit together, but at the beginning, sometimes people's behaviors are so severe that you must address the behaviors right away to give them scaffolding support to help at least manage them to the point where they're not going to hurt themselves, right? So it depends on what the alcohol problem is. But the first few sessions are going to be spent looking at details of the addictive rituals, right? Because within the details of the addictive rituals, you're going to see core needs. You're going to see where the attachment tears are that are fueling some of these addictive behaviors. So in order to do the assessment, you're not going to just look at, okay, so you have, yes, you're going to look at, you're drinking 5 or 6 beers every night, more on the weekends. You're going to look at also what the days are like. What happened before they got to 5 or 6 beers every day? When did it start? How did it start? What things were going on right before they would pick up alcohol? Right? And you're going to go back from as far back as when they picked up the behavior. What was going on then? What might have been the function of picking up the beer? Are they social drinkers? Are they isolated drinkers? That's going to tell you more about the attachment needs when you're looking at those things. Those are not things that are typically looked at in addiction treatment. So you're going to factor all of those things in when you're looking at treatment and your case conceptualization.
It's such a holistic lens. You're looking at so many factors, and you're looking at the situation around the behavior to understand what's going on, but also the different attachment dynamics at play as well.
Yep, you are. And it's not about, now some people might criticize this with, oh, you're just giving them an excuse to continue the addiction, but that's absolutely not true. First off, no one wants to be addicted to anything, right? There's this odd thing when people say, oh, you're giving them permission. No one wants to be an addict. They don't know that there's another way where they could feel better.
Just as you say that, I'm just like, yeah, how could you ever judge somebody for struggling with an addiction? Like, it's absolutely crazy. They're suffering so much, and to add a punitive layer on top of that is just so ridiculous. So earlier you said something which really jumped out at me, and you also sent me a bit of information about this before our interview, was this idea of empathic confrontation.
Yes.
What is that, and how might that look in practice?
So empathic confrontation is a way of approach when you can see a behavior, a thought, a pattern is not functioning well for the person, but the approach is empathy for why they're doing it, and simply confrontation for the how they're trying to achieve it. Right? So it aligns you again with the person's core needs and healthy adult. Like, hey, of course you want to go back to this. It's been the only way you have felt okay in the world, that you have felt like you fit in so far. But I think you and I both know, when we look at it, the behavior itself ends up hurting you in these ways. So we need to find a way for you to feel okay in the world without also doing this, right? That's empathic confrontation.
So you have compassion for the why, but you confront the how.
Yeah, that's in a nutshell what empathic confrontation is.
Makes a lot of sense. Okay, just a few more questions to wrap up here now, Liz. We're asking all of our speakers this. Basically, if you could write a letter to everybody in the world struggling with addiction, what might you have? What would some of the key points that you'd have on that letter? What would they be?
I know you're suffering, and I know you're suffering mostly alone in your own thoughts, struggling, right? And I see you. I see you, and I know your struggle, and you don't know that there's a way out, but there is. Right? And if you want help, like real help, someone who can really see you and understand what's happening, right? I would honestly look at schema therapy as a way of actually feeling better, not just stopping a behavior, right? Feeling really healed and becoming who you want to be, aligned with your values and who you really are. You can do this. And I know you have probably faced many, many people who, or society or your culture, who has given you the message that you're bad or you're defective or you're shameful. And I'm here to tell you that that is absolutely not true, not even close.
That's it's very well said, Liz. Thank you for sharing that. And then we spoke before about books you'd recommend
Yes.
for mental health professionals to read around addiction. What would your three recommendations be?
Chasing the Scream by Johan Hari, which talks about the beginning of the drug war and really why maybe treatment became as punitive as it is. Certainly the Schema Therapy Practitioner's Guide, and In the Realm of Hungry Ghosts by Gabor Mate. If you really want to understand the experience of addicted people, I highly recommend that book. The pain of addiction is there.
And just to wrap up, where can people learn more about your work? I know you do trainings and things for
I
mental
do.
health professionals.
I do.
Where can people find out more about that there?
I'd go to in fact, I have a 6-module training out on using schema therapy for addictive disorders, and that can be found on schematherapytrainingonline.com.
Brilliant, brilliant. Well, Liz, just want to say a huge thank you. As I said before, this has been an absolute masterclass in schema therapy
Thank
for
you.
addiction. So I really appreciate it, and
My
just want to wish
pleasure.
you the very best going forward.
Thank you. Thank you. And thanks for your work.